Good morning, everyone. Since we only have 5 minutes, I chose to use a Prezi so we can fly through this topic. But because there's so much to talk about, I want you guys to realize that my back to basics message to you guys is really about EKGs, and I'm using the Syncope just as an example. So I have really two messages. The first one is that when you get an EKG, you want the world to stop. You want to be able to look at that EKG carefully. I think too often we get EKGs, we sign them, especially if you're a senior resident or attending, and you keep moving. But the EKGs can really save someone's life if you don't miss those subtle clues. Now, the second message is, how do you not miss those subtle clues? And you have to look at an EKG in context, which is the most important message today. So if you look at an EKG and look for ST elevations, T-wave inversions, it doesn't make sense if the guy's 21 years old and has a syncopal episode. So you really have to think about context. You wouldn't, a young patient with syncope, you're going to look for delta waves and prolonged QT and things we're going to talk about, but you wouldn't do that necessarily in the older patient with chest pain. So again, context is everything. Now, syncope is a huge subject matter, which I'm not going to cover. If you're interested in learning all about syncope, one of our attendings, Dr. Strayer, has come up with a beautiful algorithm. If you write Strayer syncope algorithm, you'll find it in Google. But what we're going to talk about is just one small piece of it, which is the EKGs. So here we go. When you get an EKG with a patient with syncope, these are the things you have to look for. Arrhythmias. You look at the QT. Is there a right bundle branch or something that looks like a right bundle, which I'll get to? Is there a delta wave? Is there signs of LVH or just a lot of strain pattern or high voltage? Is there right heart strain or is there some low voltage type EKG? All right, so a lot of things to do. So here we're going to jump right in. So arrhythmias. Are you going too fast or too slow? Because that's going to cause you to hyperperfuse your brain and you're going to pass out. So you got to look for heart blocks as well. Look at this EKG. Could look pretty normal unless you look for a P wave before every QRS. So actually, so there's a P wave. There's a strange looking P wave. So you keep going. If it doesn't look right, you want to march these things out and look for the heart block. All right. So the QT. Here's the quick and easy way to look for prolonged QT. If your T wave is more than halfway to the next QRS, you should think that it's prolonged. But really, what we all do is we just cheat. We look at the numbers, which is okay. The numbers are pretty accurate. If you try to interpret the EKG with the machine's interpretation, you're going to be wrong often. So here, the QT is prolonged, and it is closer to the second QRS, but you might not notice it. So always cheat and look at the numbers. All right, so important point. This is how you're going to save someone's life. If you get an EKG that looks like an RSR prime or an incomplete right bundle, you should be thinking Brugada syndrome, especially if you see a little ST elevation there. This is a channelopathy, which causes people to pass out because they have a polymorphic VT, which is usually transient. So look for this, and most of us can't remember what this always looks like, so you look it up. Here's another example. It's this saddleback type deformity. Here's some more pictures. This is what Brugada syndrome looks like, and again, you can get a polymorphic VT, and it's usually transient, but these guys will do well if you tell a cardiologist, and they'll end up getting a defibrillator. All right, WPW, you guys know this. There's an accessory pathway, but again, these guys can go into VTAC, and so you want to look for these subtle things. EKG looks pretty normal. You want to look for these delta waves. You want to look really closely to see if they're there and if there's a short PR. Because these people, again, need to see a cardiologist, and you can save their life. If you didn't see it on the last slide, here's just another one. All right. If you see an EKG with a lot of voltage, you should be thinking about left ventricular hypertrophy. And then you can look up how to actually diagnose left ventricular hypertrophy on EKG. But you want to be thinking for young people, hypertrophic obstructive cardiomyopathy, and for older people, aortic stenosis. Again, these are important diagnoses to catch on EKG. Here's just another example, a lot of voltage in AVL and in your anterior leads as well. You guys have probably heard syncope. I've heard it so many times, and it's actually kind of annoying to me because people keep saying syncope, but I keep saying that because it is actually memorable. When you get a patient with syncope, think about PE and all the findings. Right, and all these things are really just right heart strain patterns. So right bundle branch, deep T waves anteriorly, and an S1Q3 T3 pattern. Here's a rhythm strip. Actually, this is a 12 lead from EMS. There's a tachycardia, and if you look closely, you get your S in 1, Q in 3, and T in 3. Again, things that can be easily missed unless you're looking for it. Here's just another EKG with some of the other signs of the T-wave inversions, incomplete right bundle branch pattern, and the deep T-wave inversions. All right. So if you see low voltage, you should be thinking there might be a pericardial effusion obstructing the heart, and again, you hyperperfuse the brain and you pass out. Another sign is if you see high voltage, low voltage, higher voltage, low voltage. This again is a sign of electrical alternans, and you should put an echo on the heart and diagnose their pericardial effusion, and you'll be a hero based on your EKG. All right, again, this is the list of things, and the message is when you get EKGs, save your brain power. So when a nurse tells you that a patient needs 5 and 2 of Haldol because they're spitting and swinging, you don't have to think too much. Give them the medicine. With an EKG, you really want to stop, make the whole world freeze for a second, and look at that EKG, put it in context, and look for your specific diagnoses that you're thinking about. And that's all I have for you.